All right.
Okay, I think we'll go ahead and get started. Dr. Phillips, going to share some valuable information about non-invasive ventilation in palliative medicine. So the floor is yours.
All right. Well, thank you guys for joining in, and I'm kind of jealous of those who are joining virtually today, but for those of you who won't be here later, we'll have a demonstration of some of these devices later on after we talk about them. But today we wanted to talk about non-invasive ventilation from that palliative care perspective. We see a lot of patients come through who are either on it in the ICU or for other reasons, COPD, neuromuscular disease. They're using it when we come across them. With that, I'm going to go ahead and get started. We're going to talk about, well, first of all, disclosures. I received no third-party compensation from Phillips Respironics. We'll be talking about their Trilogy machine today, but we actually use, there's a few different brands out there that we'll use for our patients. The other thing to know today is that titration and monitoring really does require serial arterial blood gases, pulse oximetry, if you're going to be doing this from more of the medical standpoint, talking about long-term survival, COPD management, or other reasons for this. But because of the palliative purposes, we can do this and titrate to comfort and not be so concerned about getting ABGs. So we won't be talking about maintenance or monitoring from that standpoint. A brief outline, we'll talk about some of the history, then get into some of the management, and then look at some palliative care considerations, both with goals of treatment and withdrawal. If we have time, we'll talk about non-invasive ventilation in neuromuscular disease. When you guys get the slide deck later on, there's plenty of slides that are hidden, so there's a lot more resources. I guess you can call them PowerPoint Easter eggs if you want to, but we'll start with non-invasive ventilation and a brief history. Let's see. Is there a way to minimize this up here, guys?
Yes. But not that mark.
That whole bar, we could get.
I don't know.
Okay. I will just go ahead and bear with it. So there we go. All right, now I can see my screen a little bit better. All right. So a little bit of history first. Ventilation really started more with negative pressure ventilators. Now we're using more of the positive pressure. So when we talk about negative pressure, we're really talking about creating a pressure that transmits through the chest wall and diaphragm to assist in that inhalation. And it allows for passive recoil, and that promotes the exhalation. So you'll see in this picture, this is one of the first devices for non-invasive or for a negative pressure ventilation, where the patient sits in a sealed chamber, the pressure kind of drops around the body, allowing for that inspiration to occur. So you can see this is something that can be done, but I'm not sure it really improves much from the quality of life standpoint if you're sitting in this chamber the whole time. 1927, with the polio epidemic, we had the invention of the iron lung, which is the same sort of concept, only the patient is laying in bed with the seal right around kind of the neck. So the body again is encased in the negative pressure, and there's a diaphragm at the bottom of the feet. And just to show you how high tech this technology was, we got fans and flywheels and cranks. And if you want to turn up the ventilation, you just crank that wheel. So we've moved a long way from here. One other version of this is the poncho wrap. I'll just leave it at that for now. I want to move on to more abdominal respirators that we've used in the past. This really depended on moving the abdominal viscera to create that negative space, allowing for that air movement. So we had the pneumo belt, which created a lot of pressure and release right around the abdomen. But then my favorite is the rocker bed. So patient is strapped to this bed and it flips you from head to toe. So that viscera moves and it moves that air in and out. So again, I'm not sure what it does for quality of life, but at least you're alive. So this would definitely require a goals of care conversation before strapping me to that thing, I think.
Scary.
Before we get into the positive pressure ventilation, I wanted to go over some terminology. We have a CPAP, which everybody is familiar with the idea. It's a continuous positive airway pressure. It's not technically ventilation. It's providing a constant stream of pressure at the same level to maintain a patent airway, and then the patient breathes above that airway. So it can reduce hypercapnia by relieving muscle fatigue and augments that central ventilatory drive. And again, sleep apnea is where we see most of this. We move up, or before we get to the next thing, I wanted to quickly, and I don't know why BiPAP didn't show up. Hopefully that's coming down the road. I wanted to review obstruction and restriction for the sake of this talk. Obstruction is more where we've got flattening of the diaphragm, airway is very wide open. We've got air trapping, so things like COPD, cystic fibrosis. Restriction is really more where we've got tightening of the muscles. Either there's cancer in the way or neuromuscular weakness. There's an increased elastance, which doesn't allow for the lungs to expand to inhale. And then you can get the mixed pressure or mixed pictures too, where you might have COPD and a tumor or something of those sorts. But the non-invasive ventilation is going to help with both of those. Let me just, okay, BiPAP is coming. All right. I wanted to, you guys should know about the difference between types of ventilators as well, just as a brief overview. You can either adjust the volume and kind of set a target volume for ventilators, or you can adjust the pressure and set that limited pressure, which means there'll be more of a variable tidal volume. With BiPAP, now this is the bi-level positive airway pressure. This is a pressure limited ventilator, meaning that you set that inspiratory pressure, which is the IPAP, and you set the expiratory pressure, which is the EPAP. Inspiratory pressure is higher to allow that airflow in, and then the expiratory pressure is lower to allow that airflow to kind of exhale much easier. The BiPAP is triggered by the patient breathing, so it matches the patient breathing efforts. So we get something a little more comfortable than the CPAP. With the BiPAP, because it's pressure dependent, it's welcome, John.
Good morning.
With the BiPAP, because we're varying that pressure, the tidal volume is going to vary a little bit as well. So just as an example here, if you set that inspiratory pressure to 15 and the expiratory pressure to 5, you're going to get that total of that 10 centimeters of H2O is going to determine that volume for you. Versus a IPAP of 10 with an EPAP of 5, you're only getting that 5 centimeters of H2O. So a smaller overall tidal volume there. The advantage of the BiPAP over the CPAP is it's active ventilation, so we're not just splinting the airway open. There's a lower mean airway pressure, so we have less of that high pressure, so patients tolerate it better. And it rests the ventilatory muscles. Muscles don't have to work so hard to exhale. We can see that it'll actually help improve respiratory acidosis and more normal return of the chemoreceptor function. So overall, if you have the choice, BiPAP may be better for the patient than CPAP. Again, it can do breath by breath adjustments. So it's triggering based on what the patient is doing and breathing. Because it's set to meet that certain pressure, if there is an air leak around the mask, it's going to continue to increase that pressure until it meets that target pressure. So we get that continuous flow. And we can also set a backup rate. So if the patient is not triggering breaths after a certain amount of time, it will trigger those breaths itself. And then there are also mechanisms to terminate inspiration. So those of you in the room can't see this because of the bar in the way, but there's an inspiration expiratory ratio. So you set that on the machine. So after a certain amount of time of inspiration, it'll automatically start the expiration process. So there's a lot of these devices, a lot of them may be using them at home, but the key is if you're going to be using something like this at home, it is a sealed system. So you need to make sure that there's alarms to let you know if something's going wrong so that somebody can be there to assist and help with troubleshooting. So this diagram really does a great job of showing the difference between spontaneous breathing, what a CPAP is doing and what a BiPAP is doing. So down in the lower left corner here is just atmospheric pressure. We're breathing in and out, getting that inspiration and expiration. CPAP just shifts the curve up. So you got inspiration and expiration. It's just at a higher atmospheric pressure or environmental pressure. The BiPAP then allows for still that baseline closer to 10 or whatever you set that expiratory pressure to, but then it allows for that inspiratory pressure to be higher. So you're getting a lot more of the volume up and down, kind of adjusting to what a normal breathing would be.
Can you hold on that slide just for a second?
Yeah.
I think this so effectively clarifies visually what we're doing, and I just takes a moment to realize, and then it seeps in, okay, well, that's why the CPAP will work for obstructive apnea, because of just raising that.
Just shifts the curve.
And then the first time I saw this, it was really one of the very first times that it made sense why we need the BiPAP in ALS patients that have no inspiratory, that they lose their inspiratory capability. So I think I just like that visual. I just wanted to hold it for a second. So
Yeah.
You go on.
So soak it in.
Thanks.
And again, you guys will get the slides later on. So when we look at non-invasive ventilation, so we're going to take it a step further beyond BiPAP at this point. There's two models on the market. Trilogy came out first, and that's the one on the left here. On the right, you see the Astral ventilator, and that one is a slightly newer model with a few different things, and we tend to go for that one first if we can. But take a look at the picture on the bottom. You can see how small these are. These really are tiny little machines that people can carry around with them, which makes it very easy to carry around in the home. So we'll talk a little bit about the interfaces and all the setup that goes with it too. Before we get there, I wanted to just mention volume cycled positive pressure very quickly, because it's going to set us up for the next slide and what those non-invasive ventilators do. So the only takeaway you really need from this slide is that it sets high pressures to overcome airway obstruction, reducing compliance, allowing patients to return to a more tolerable level of breathing later on. So that brings us to AVAPs. So AVAPs is what these non-invasive ventilators are doing. It stands for average volume assured pressure support. So it's providing the pressure like a BiPAP does, but you're setting a target tidal volume. So you're trying to get that average volume in, and it uses the pressure to get to that target volume. So it's a mix between BiPAP and that volume cycled, which you saw on the other slide. So the inspiratory pressure, rather than being one set pressure, is going to have an inspiratory range. The expiratory pressure, again, is going to have an expiratory range. So you might set that expiratory pressure to say 5 to 10, and that inspiratory pressure 15 to 20. And then the machine, through its algorithm, is adjusting how much pressure is needed breath by breath, so that we're getting that average tidal volume, but the pressure is going to vary based on the patient needs. And just for fun, IVAPS is intelligent volume assured pressure support. That just subtracts the dead space, so it's more of an alveolar ventilation, but nothing you guys need to remember. But this is my other probably best diagram of the other best diagram, I should say, of the PowerPoint. And it really explains what that IVAPS machine is doing. So you'll see on the bottom, you've got this blue dotted line. This is the target tidal volume that we're trying to hit. That tidal volume is going to vary based on the patient circumstances and compliance, elasticity, those sort of things. So you'll see that we've got the pressure support just above it. My mouse isn't working very well right now, but you've got this pressure support. This is the inspiratory, or sorry, this is going to be that expiratory range here, the expiratory, and then the inspiratory range. So what you see is as the patient takes a breath, it's staying within this inspiratory, expiratory range as long as it's meeting that tidal volume. It's still doing that same thing, but suddenly that tidal volume is dropping. So as the machine senses that tidal volume dropping, it's pushing up that inspiratory pressure, and expiratory is staying the same. Inspiratory is going up and it's keeping that expiratory at the baseline. It's given more and more pressure breath by breath, and you can see the tidal volume going up. As it averages out, it's getting above the baseline there. It's going to start reducing those pressures back down, back to where it was. Suddenly the volume drops again. This time the machine, the algorithm says, you know what, we need to bring that, shift that whole curve up again. So the pressure, inspiratory pressure goes up, but so does the expiratory pressure. So it's shifting everything up, and we're actually exhaling at it at a higher pressure to maintain those breaths. And so it's calculating for every breath, trying to maintain that average tidal volume. So that's where it can be very dynamic and very much more comfortable for patients over time. So this kind of explains what we just talked about. I like that this can automatically adapt to disease progression. So you just change the settings. You've got the respiratory therapist who can go out and change inspiratory and expiratory pressures as needed. And it can actually do a better job of reducing CO2 if that's an issue for your patients. So let's look at some of the interfaces. The most popular is the nasal mask. So the model on the right there goes over just the nose, and the model on the bottom is a small mask that's actually just a different form. Let's see if I can get this for you guys here, just so you can see how that one looks. So the issue with nasal pillows is that you got to be able to maintain a mouth seal as well, because as that pressure goes in, if your mouth is open, pressure is going to come right back out. So patients tolerate it better, but you've got to be able to maintain that seal for breathing. And then we have the oral nasal mask here. So this is actually more often used with respiratory failure. Two different models here. The one on the right is your typical mask that you see with ambu bags and everything else. But then on the left here, this is a combination of the nasal pillows with the mouthpiece. So I've got a lot of patients who find this one very comfortable. It's smaller, compact, it feels less claustrophobic. With the original model, you get a lot of issues with pressure sores across the bridge of the nose. So patients find ways around it, but nasal pillows just tend to be more comfortable in general. And again, with these, you need alarms and supervision if you're going to be using these at home. And then for some people, we find, particularly with spinal cord injuries, those sort of things where you need just a little bit of supplemental air, but not necessarily the full ventilation, you can do something like the sip and puff or the gooseneck stand, where the patient puts their mouth around the mouthpiece, they trigger a breath, and it's going to blow that air right in for them. So this is more of a PRN as needed sort of ventilation system. Be aware, cough assist is something that exists. The technical term for it is the mechanical in-exoflator. And that's because that's exactly what it does. So it'll insufflate the lungs to 50 to 60 centimeters of water and then rapidly exsufflate. So it drops from 50 to -50 in 0.02 seconds. So that's an extremely high velocity for that pressure drop. And it creates this with the exit of all that air, triggers a cough, helps pull up all the secretions that may be stuck deeper down in the lungs and the airway. So you may need to do higher pressures for a trach, but the other thing to keep in mind is you need that bulbar function. So if somebody has a lot of collapse, soft tissue issues, or can't maintain their soft palate open, that rapid change in pressure is just going to collapse that soft palate area around the oropharynx, and you're not going to get a good effective cough. So let's talk a little bit about management just to give you guys the basics. Again, I'm not an expert in ventilator management. I feel like I'm getting there after working more with my patients, but keep in mind that when you recommend a non-invasive ventilator, it comes with a respiratory therapist. So when we're doing home ventilation, that respiratory therapist comes out, helps set up the machine, put the initial settings in, and will work with you to adjust those settings to get it to a comfortable level. If patients are having problems with the machine, you call the representative, the respiratory therapist. They come out, make the adjustments that are needed. So they're great at helping find the right interface for the patient, get the right settings, and set it up for the most success for the patient. Usually with the BiPAP, we're starting about 8 to 10 centimeters of water for inspiration. Expiratory is 4 to 5. This is more for reference later on. I don't think we need to go through those numbers now, but adaptation is key. So as people are starting, you want them to be able to get used to the machine. So I find this quote almost laughable because it's easier said than done. The patient is encouraged to relax and let the ventilator do the breathing. That's really what you want to do, but when you put this mask on and it starts blowing air in, first thing you want to do is stop all that air from coming in. So there is definitely a learning curve to it. When you're starting, claustrophobia can be an issue. Maybe let the patient hold the mask to their face to get an idea of what it's doing. Diversion, such as trying it while awake before trying it at night. So watching TV, reading a book, maybe a low dose benzodiazepine may be good. But it really comes down to those short 1 to 2 hour trials as well. So I tell my patients, try it, do it as long as you can tolerate it. Tomorrow night, you might get 2 or 3 minutes more than tonight. And you just slowly build that time over time. And it can take 2 or 3 months before people are completely used to it and able to sleep through the night. That being said, in our patient population with neuromuscular illnesses, that's where we're really starting is we recommend nocturnal use. As disease progresses, we'll start to use it during naps during the day, anytime they feel like they need to do it, if they've just done a big physical activity. But over time, we start to see it become more near continuous use as that respiratory function drops. Okay, and then to adjust for comfort, again, use your respiratory therapist to help with this. They can help adjust the type and the size of the mask. They can adjust the strap tension, and then the inspiratory time. We can play not only with the pressure, but how long that time is that inspiration takes place. And then with the monitoring, you want to focus on comfort. If problems arise, they can easily be troubleshooted and push for more and more hours of use as possible. But do watch for morning headaches, daytime sleepiness. If you see those sort of things, the vent settings probably aren't right, and you're probably getting some hypoventilation overnight. So make sure that patients are waking up in the morning feeling well rested with no headaches. And again, assess every couple of weeks just to see where things are at. And again, we see the symptomatic improvement most after they're able to sleep through the night. Some people will use pulse oximetry to determine whether or not we need to use O2 supplementation. We don't typically use it in the neuromuscular setting because it's more of a mechanical issue and not a diffusion issue across the lung tissue. We'll see with some of the COPD or some of these other things, it can be used, but it increases, there's a lot of complications that can come along with it. It can exacerbate that hypercapnia, and also it may decrease the efficiency of that nocturnal ventilation. When we do use it in ALS, it's typically for somebody with lumbar weakness who refuses a trach or doesn't want a trach, but really it would be medically indicated at that time. So there is some room to use it. I think in my time in the ALS clinic, we've had 2, maybe 3 people who are on O2 supplementation. So for the most part, we're avoiding it. This slide really just kind of highlights again, watch for the morning headaches, dyspnea, energy levels. You may have symptomatic alveolar hypoventilation. So if that's the case, just make those adjustments to higher settings. The other thing to keep in mind is that these ventilators at home do have dual circuits. So you may find that you need higher settings at night, use the mask with higher settings at night, but during the day, you might be able to get away with a mouthpiece. So you can just take all the hardware and the hoses and pull it out of one output and put it into the other output, and you've got day-night use. What I've been running into a lot is people leave the machine plugged in the bedroom, so they're only using it at night, and now they're starting to ask for a separate machine to have in the living room. So they've got one in the living room, one in the bedroom, and from a quality of life standpoint, seems to make a lot of sense.
Yeah, I'm thinking the insurance company might hesitate on that.
Surprisingly, they'll approve it.
No kidding.
Yeah. So I mean, I always ask myself about utilization of resources, but
Sure.
there is that option for some people to have two machines. All right, so who benefits from this? Make sure the patients have capacity to make decisions, can interact with their environment, they can cooperate with having a mask on their face, and they don't require a lot of heavy sedation to do this. You do want to make sure that patients are able to take the mask off themselves in case there's either vomit, aspiration, or there's something wrong with the machine. A lot of the masks now actually are magnetic. So you strap on the frame and then the mask piece just snaps right to the frame rather than having all these clasps and clips. That way, if somebody has no use of their hands, but they can lift their arm up, they can still knock it off with their arm and have just kind of break that closed circuit. So let's look at some palliative care considerations for non-invasive. We'll look at the acute setting in acute respiratory failure. Chronic setting, we can use it in progressive neuromuscular diseases, sometimes COPD or some of the other pulmonary diseases. But we really need to talk about goals. What is this machine going to do for us? And can it help us reach those? And if it's not helping us reach those goals, when do we stop and how do we know we need to stop? So the next couple slides come from the Society of Critical Medicine Task Force. This was published in 2007. I checked last week for updated resources, and this was still quoted back in 2019 by another source. So as of right now, it still seems like these are the recommendations. I would imagine that if we're looking 15 years out, they've got to be talking about updating these soon, but we'll look at three different approaches. Approach number one is using non-invasive ventilation without preset limits, meaning we're going to do this until the point where we need to intubate, where somebody says, do everything you can for me, keep me breathing, no matter what that looks like. The third one is more of non-invasive ventilation for comfort measures for patients. And that second one is more that middle of the road. Patients who say, I really don't want to be intubated. I don't want invasive mechanical ventilation, but I'm not quite ready to say no to ventilation. It might be more of the time limited trial where we wait and see and monitor that patient's clinical progress over time. So when we're doing that first one where there's no preset limits and we're going full court press, you need to do it in the ICU setting. And the non-invasive ventilation stops when the patient's able to breathe on their own, or if it fails and it's not working and we need to go to more of the invasive ventilation. This one can be used in the setting of decreased level of consciousness if we're using it in that setting where we're hoping for improvement over time. So if we're looking at it and patient is lethargic and obtunded and we're not expecting it to improve, then we would need to move to more of an intubated state. The second one, again, is more for that time limited trial. The patient is willing to try it, but is not willing to do the intubation. So we know it's successful if it improves the ventilation while we're treating that underlying disease, trying to get to a point where the patient can breathe on their own. We do need to manage dyspnea in a setting like this. So the machine may be working well for them and helping them meet those goals, but it may be more uncomfortable than we would normally let somebody tolerate. In this case, encourage, support the patient. You may need to use a few other medications to help with some of that dyspnea, but if the goal is to try to improve and avoid ventilation, we might have some issues with discomfort. You stop this when the patient can breathe again on their own, or when the patient is not improving and the next indication would be go for that invasive ventilation. That's when we start having talks about transitioning to comfort measures and transitioning more to end of life care. When we are in this middle of the road sort of situation, 4 different outcomes were identified. Number one is clinical improvement, which most patients are hoping for. Number two is the other end of that spectrum, worsening followed by withdrawal of the invasive treatment is what that withdrawal of treatment means here. And that would lead to death at that time. What we may see happen is stabilization, but an inability to survive without non-invasive ventilation. So it's very important patients know that that could be an outcome. And then that stabilization may lead to number four, where patients are deciding then that they're going to extend therapy as long as possible on this non-invasive ventilation. Again, we need to discuss those clear endpoints so patients have a good idea of what could happen, and we may end up in a messier situation than if we don't start the non-invasive.
Has the technology really advanced to the point where I think I already know the answer to this, but it sort of reminds me of when we had these advanced cardiac interventions like LVADs and things of that sort, and they're really only considered to be transitional. And then they developed the technology such that they become destinations, and the intent is to stay on them indefinitely, forever, I guess.
Yeah.
And you certainly can do that now with the technology that we have with our reservoirs.
Yeah, we're seeing a lot of people doing this at home in the muscular dystrophy setting. A lot of people may be trached and have the non-invasive. It becomes a home ventilator at that point, but they'll hook the ventilator up to the trach and be able to live at home or in their facility for years and years on end with this ventilator set up. So we are getting to a point where it may be more of a destination for some people. So some people say, let's use this non-invasive ventilator, allow family to come in and say goodbye. Maybe there's family out of state who needs to come in. There is a role for that, but use caution. Patients and family really need to know what they're signing up for when this happens. So there may be more difficulty in communication. Patients may not be able to eat or drink. We will need to focus on aggressive symptom management during that time as well. And then it might just complicate future decision-making. If we end up in a position again where we're more in a stable place and non-invasive has become life support, we're going to have to circle back and have those conversations about what that role for it is again. So I just highlight again, you guys have heard this with other treatments and interventions throughout the year, but not starting a therapy causes less psychological burden than discontinuing it. So it's morally and ethically permissible to stop the machine, stop the treatment when it's no longer providing benefit. But sometimes it's worth having that conversation that, you know, it's easier to not start the ventilator in the first place rather than find ourselves in a more uncomfortable, distressing situation down the road. And finally, that third route, non-invasive as comfort measures for patients who decline endotracheal intubation. It can be used for comfort measures only. In such a setting, it may be COPD, neuromuscular disease. People can use it for refractory dyspnea. Most of the time, if we're using this in such a setting that we're really nearing the end of life, it may be something where it's bridge therapy while we're trying to titrate up the opiates or try to titrate up the other medications, the benzodiazepines, to get a patient to a comfortable level, and then we can remove the ventilator. It's best for people who still have that cognition. So if they're talking with their patient or their family, their loved ones, and it's really helping to improve their quality of life and make memories, this is good to do. But if somebody is, again, obtunded, lethargic, and we're using this for comfort measures, we can do a lot more pharmacologically to make the patient comfortable rather than having a machine like this breathe for them. So we know that it's success when it controls the symptoms and doesn't cause other problems. If it's not providing comfort, we need to stop it and pursue other means. So again, if patients can't communicate, it's not indicated to use this machine. And it may be used again in conjunction with opiates. So that being said, other people may decide, particularly in the hospice setting or the end of life setting, that, you know, I'm sensitive to opiates or I don't want to be too sedated. This is a great way to manage dyspnea when patients want to maintain kind of mental clarity or be more alert and are concerned about being sedated on these other medications. So other considerations, clarify whether it's indicated, don't offer it if it can't help us meet our goals. So goes back to eliciting goals and values. What are the patient goals? If we can help meet those goals with this, great, let's do it. But as we talk about it and you're looking at those three different pathways, you want to make sure that you're talking about those potential burdens along the way too, so patients and family can make those fully informed decisions. So barriers to effective therapy, you do need to have 24-hour supervision in these settings. If something goes wrong, you have to have somebody in the room who is able to help troubleshoot and get things back in the right order. Claustrophobia may be something you're fighting. And again, inability to adjust the mask or straps. So what can we do so that patient can feel comfortable and can take care of themselves in those sort of settings? Other things you may run into, gas and bloating. So as that air is going in, it's going down the airway, but the GI tract is getting some of that air as well. Secretions, if you've got a lot of secretions, we might be blowing some of those secretions back. So use of suctioning is important, but also knowing that there may be more of a risk of aspiration in some cases. And then mobility. Having such a small portable machine has really helped to increase that possibility. But again, these are things that people will set it up in the bedroom and it stays in the bedroom. So it really doesn't move with the patients as much as they were hoping. So with patients in power wheelchairs, okay, just checking to see if that's Jen. Patients in power wheelchairs, you can actually get a rack that you can put those machines on. So you can plug it in, charge it up. It's got an 8-hour battery life. Put it on the back of the machine or back of your power chair, and you can go wherever you want in the community for up to 8 hours. And then all you have to do is plug it in again wherever you are. And it does allow people to get out and about if that's something that they want to do. Again, whenever we're talking about this, we're talking about a time limited trial, or at least framing it in a setting of this is why we're doing it now, but we may find ourselves in a situation later where we'll have to reassess. So conversation with my patients typically is, let's do this for the dyspnea. Let's do it to help with your symptoms. People find it helps with fatigue, energy levels, but we may find that 6, 8, 12 months from now that you're using it all the time and it's become life support. So we'll have to talk about what that means down the road. And again, you can use benzos or opiates as needed along the way. Again, if you can have the conversation in the outpatient setting, that's ideal. Having it before it becomes an issue again is a good deal, rather than having patients make a decision kind of in the panicked moment there. And then continue to reassess. Is this still working for you? Is it still meeting your stated goals? So when we look at where these different pathways can be done, category 1, where you're risking intubation or you're accepting intubation as the next step if you need it, you should be doing the non-invasive in the ICU. That second category can be done in the ICU if patients are critically ill, but if they're stable, they can be transferred to a facility, usually a long-term care facility that has trained personnel who can help continue to manage the medical needs while we're waiting for that respiratory improvement. And then category 3, more of the comfort-based care, can be done at home, again, with appropriate supervision. We do find in the neuromuscular realm, as disease progresses, caregivers get good at managing different things along the way. So for a lot of our ALS patients, muscular dystrophy patients, it's something that I won't say comes naturally, but slowly as we add more on, it's something caregivers are very capable of learning and doing and are willing to do. We just have to watch out for that caregiver burden and that burnout that can come with another device and another care. So at home, again, you need trained nurses. The respiratory therapist is available to help with all the troubleshooting and getting things set up. And then having a physician oversight is important as well. Families should be familiar with the devices. Again, they need some training on what to do and how to work the machines. And again, not indicated for actively dying patients. So if somebody is actively dying, that's a good time to take the machine off. Use more of the pharmacologics to manage any dyspnea that may be there. So just so you know, it can be done. People who are on tracheostomy can switch to non-invasive ventilation if their clinical situation changes. They can be decannulated if there's enough bulbar strength. And it may improve quality of life if somebody's on non-invasive rather than a trach. And again, these machines are portable and can become that invasive ventilator. So if you're on a trach, you can plug these in to the trach, but vice versa. If you are on a invasive ventilator, trached in the ICU, and you want to go home, who wants to go home for whatever reason, and we've got the support at home, you can take them off the ICU ventilator and put them on non-invasive ventilation. So it requires a lot of talking, care, coordination to make these things happen, but they're not out of the realm of possibility. So with some of the time left, let's talk about withdrawing non-invasive. It really comes down to what is the setting, what are our goals? So when we're making this decision, we got to ask ourselves, who's making the decision? Is the patient able to make the decision? If not, who's a surrogate decision maker? What sort of questions does the family have? What things need to be clarified? What is the evidence? What's the clinical picture looking like? And how does that fit in with the patient's goals and values? Does the patient know that they will die as a consequence? We have to make sure that there's no coercion. So we need to make sure that as we make this decision, you're having a non-confrontational, non-judgmental conversation with the patient and family. You also want to make sure that the patient's really kind of settled on the decision. You don't want them to say, today, I don't want this, but tomorrow, yes, I still want to keep doing this. You want to make sure that it's something they've had time to think about and have settled on the decision and are really saying, there's no turning back at this point. This is what I want to do. Again, assess the capacity. How much can the patient help us make the decision? And then you want to summarize those risks and benefits with all stakeholders so they know what's involved. So then once we've made that decision, where does the patient wish to be? Is this something that we could be doing at home? Is this something we're going to be doing in the ICU? It's good to provide that anticipatory guidance. Tell that patient, tell the family, this is what we expect to happen. Prognosis may be limited to hours, might be a day. If there's any sort of secretions, dyspnea, we will be aggressively treating those with medications to help along the way. But more importantly, who does the patient want to be present? Are there friends that need to be there? Family members? Are there people who need to fly in from out of state again to say goodbye? Address a lot of these concerns and have that plan in place before moving forward. And know that the patients have the right to stop at any time. But once you decide that, yes, we're going to go ahead and do that withdrawal, within a couple days is best. Usually things can be set up in about 24 hours to make a successful transition. But you don't want things to drag out. So you don't want to say, yes, I've decided to do this, but I'm going to do it 2 weeks from now, because that can really add to stress, add to anxiety. And now there's suddenly something that's booming over everybody's head. So when you do go ahead and do it, make sure that the families had time to ask all the questions they need to. And then once we're ready, we can go ahead and do it. But again, that window is usually 24 to 48 hours in which we can do it successfully. Again, address the dyspnea and distress that may come along with it, and then support family members before it happens and after the withdrawal happens as well. So with that time, I'm going to pause and ask if there's any questions first, because I could keep talking about neuromuscular disease for a long, long time, but I want to make sure that I answer other questions first.
Good time to speak up if anyone's got any questions or curiosities that have arisen at this juncture.
Joel,
Yeah.
this is Ken. What about the patient that you're transitioning? Let's see, let me set up this question so you can understand it. They're not quite ready for hospice. Maybe they're at home, but they're precarious. They keep bouncing back to the ER, right? Back to the hospital. And have you had trouble getting approval for these sorts of devices there in the home? Or is it easier to do it, if they were acutely ill in the hospital and now they're, you know, stabilized and going back home? Does that make sense?
Right, right. Now, I think you're probably gonna have an easier time making it part of that conversation if they're in the hospital.
Sure.
Because you can assess their respiratory function, those sort of things. What we usually need to do in the outpatient setting is at minimum know what the pulmonary function tests are. From my standpoint, it's really more the MIP and the MEP, so looking at the mechanics of breathing and that forced vital capacity in a supine position. If it's
Okay.
more of a COPD sort of an issue, the pulmonologist is very helpful in helping make that determination. So I would start with a pulmonology consult to really assess for that need. But yes, it can be done in the outpatient setting. Not only will you need PFTs, but oftentimes we need to get nocturnal oximetry to look at how well they're being oxygenated at night. Some people may need a sleep study to rule out sleep apnea because the insurance company is going to want to pay for a CPAP before they're going to be willing to pay for non-invasive ventilation. So working with your pulmonologist and getting some of those tests done can really make the argument. But it's more that situation of where we have time to do that. So if they're end stage really bouncing back and forth between the ER and home, it may be worth having that conversation on the inpatient side of things.
Yeah. Great. Thanks.
Other questions?
I'm curious about the use of this as a bridge for patients that are on high flow that are otherwise transitioning but really don't want to make that transition in the hospital, and whether or not that's actually feasible. That's more of a staff availability and having the resources available in that other setting. But
So are you talking about like that patient that wants to get home,
correct?
wants to do hospice at home, but it's the difficulty in transporting home because we're on high flow?
Had several patients that are like end-stage pulmonary fibrosis or pneumonitis as a result of COVID, and then they've stabilized on high flow, but we're still having those conversations. They don't want intubation, they don't want a trach. They would really rather not die in the hospital, and they're completely lucid and relatively stable on the high flow. But how do you get them from point A to point B, knowing that as soon as the high flow is pulled off, that's going to start to end? So I've been curious about that, but then you have to have the people that are comfortable with managing the non-invasive ventilation in those different settings.
I guess the other key is, has the technology of high flow changed at all that allows us to be able to use that as the transitional tool and take that?
Right. And I haven't seen the mobility on high flow yet, but I don't know, maybe others.
I've heard of hospices getting creative and hooking up 2 oxygen tanks and things like that.
We got 6 in ours.
Yeah, and Dr. Dupuy likes to use the pendant a lot to get people home. So I know we still don't really have the technology to do high flow at home that I'm aware of. So I guess it really comes down to what are the goals again? Is this something where we're saying we want to go home, we want to be with hospice, we know we have weeks or months to live yet? Or are we saying we want to go home, have hospice come in, and we know that we're going to remove the ventilation when we get home? I think there's 2 different scenarios there. And each is going to involve conversation with the hospice and what hospice can provide as well. And how can hospice meet those goals? I think in the first setting, there may be more of an argument for that non-invasive ventilation if we're going to be doing it for weeks and months and it's symptom control, right? Versus we need to transport home so we can die at home. Then maybe some of the other things that we're doing may be more appropriate if it's more of that short-term kind of window of time just to get them to that spot. I don't know, John, I'd like your input as well from the hospice standpoint.
Well, we're obligated to provide whatever it is that meets the patient's goals and provides for some comfort. There's always a conversation, the administrative offices of hospice, about the cost of these sorts of things. And the size and the resources of the hospice will sometimes dictate whether that's just a footnote or whether that's a legitimate barrier. I think that I rely back on Mike Raffleson's a comment about eligibility and resources, to provide for the patient. And his third bullet on that is, does the hospice have the resources to be able to provide that? And so, I certainly have cared for patients at home on home ventilators. That's, I've done that. I've done, home extubations. We've had certainly numbers of folks with advanced neuromuscular disease who have been on their, trilogies and other sorts of machines for extended periods of time. So I think that it needs to be included as part of plan of care for those individuals who desire it, and that does meet their self-determined life closure goals. And I think one of the things that really I thought was very, very useful, as well as some of the technical information here, is the number of times that you referenced the need for the conversation about the goals of care, and the fact that these are complicated questions and have a lot of unintended consequences to these sorts of interventions. So I think that just again reinforces one of our absolute strengths of our profession, is our ability to help patients navigate that. At the end of the day, if you've navigated those conversations, and this is some element of advanced technology to support their breathing status, whatever that might be, whatever their disease, I would go on the record as saying we as hospices should provide those. Again, with the caveat that if you're a small hospice and census of 12, and you've got a small budget and small staffing, and now you're putting that resource that is both time intensive, dollar intensive, and staff intensive, may not be feasible. But the default should be that we should have the capacity to provide that for our patients.
Hey, Joel.
Yeah.
This is Ken again. There actually was a case report in the ER literature about a patient on a ventilator that, but was, if I remember correctly, was trached and awake and alert, and wanted to discontinue the ventilator. And they were able to get the patient home, but it took an enormous amount of pre-planning with EMS. And so they actually had to have the EMS medical director out on scene to kind of provide oversight, to extubate, to start the medications, to get her comfortable. But it was a success. I know Dr. Prees and I had many conversations about sending patients home, and we worried that the patient would pass in the ambulance, right? That they were so unstable, and we'd have to have those conversations with the family. So like Dr. Mueller said, a lot of variables to consider.
You mentioned that, Ken. The last extubation I did at home, they were transported obviously by ambulance, by EMS. The EMS medical director was not there, but I was. And so, but the EMS team stayed on site. I did the extubation, and then the EMS took all the equipment, took it back to the hospital for us, which I thought was a nice little, sometimes the logistics of these can be challenging.
Yeah.
And
Agreed. Yeah.
And that was about as slick as I've seen it, because they just said, hey, we'll hang around. And they didn't need to be there until the patient died, just until they could reclaim the equipment, deliver it back to the hospital. So there was no need to have to monkey around with who's paying for what and how do you transition the accounts. And as the hospital said, you can borrow for a couple hours.
Nice and smooth.
So nice and smooth.
Yeah. Yeah. Well, and I think the good news is that this sort of thing is getting to pre-hospital, where the EMS professionals don't want to intubate a hospice patient. They get it, but frequently they're protocolized and they have no choice. And so I think medical directors are starting to get savvy enough to develop hospice protocols that allows EMS other options, right? So.
And it's amazing to see that actually come to fruition, Ken. I know that that's one of your big things, is kind of getting palliative and hospice into the ER setting. And there are emergent palliative needs at times. And it's great to see that we're starting to see some of those protocols. Any other questions?
Yeah, Joel, it's Dini.
I see me.
Hey, just wanted to ask about prognostication for ALS patients. It seems to be a little bit trickier, particularly when we have patients who may be on um, tube feeds or, they have just other things that they have in the home for kind of prolonging life, but also then how do we prognosticate? Like how can you guide us in the prognostication of ALS patients?
Let me pull up this slide for you guys. Oh, I guess I'm starting from the beginning. Oh, there it is. Right here. So this came out a couple of years ago, looking at prognostication of patients with ALS with everything that we can do to them. So from the disease onset, if there's no non-invasive ventilation, in this study, the average length was about 15 months. If you get, and this does not account for PEG, so most people who are in more of these advanced stages already have the PEG in place. So if we've got non-invasive ventilation, no leaks, no obstruction, people can live for about 29 months. But then you add the cough assist and it may be longer, but once somebody's trached, and we're doing that mechanical ventilation, we're looking at 6 years from time of diagnosis. So that you're absolutely right. That prognostication goes out much farther. And now these are probably the settings where they're being well taken care of as far as being turned in bed, being bathed, washed, avoiding bed sores, avoiding UTIs, pneumonias, those sort of things. We can go out pretty far. We always do have those other medical complications that can get in the way, but that's why one of the things, ALS itself is still a catabolic disease. And so that's one thing that I'm always watching is what is that weight? Are we seeing muscle atrophy? Are we seeing some other things that would, other than the vent, show that there's progression?
Okay, thanks.
Morning, John. Fred Van Alstyne. This is for Dr. Mulder. How do you handle the distraction of hospice enrollment if you're discharging them home to extubate with the anticipation of passing pretty quickly? How do you manage that distraction that's involved with the enrollment in hospice?
So you're referring to just the abject administrative processes of getting someone involved with hospice, correct?
Correct. That's a fairly involved process that can be highly distracting to the family that might want to be spending time with their loved one.
So I think that there's the practical and then there's the regulatory. I think that in those particular circumstances, what we have done is saying, what do we absolutely have to do that legally allows our hospice to engage the patient family and start getting the work done that needs to be done for them. So you need to make sure that you're signing the forms, and that seems to be one of the most important things, and that's what regulators look at. Now, some of that's a payment issue, and I think in the midst of some crisis, I've seen some hospices would say, we need to do what's right for the family. If we can turn around and get billed for it and get paid for it, obviously that's a benefit. But get some forms signed and then get out of the way and let them do what they need to do. We can collect information that finishes checking the boxes and those sorts of things later on. There's a lot that we do in the administrative hospice process that is necessary for billing. There's a lot that we do that is necessary for appropriate patient care. These sorts of patients that are coming home in somewhat of a crisis mode, we know we're going to have a relatively short trajectory, maybe hours, or in some cases, you get home, you extubate, and you've got minutes. So you spend as little time as possible getting the appropriate infrastructure set, the boxes checked that you need to, the signatures that you need to, and then step out of the way and do the rest of the background. That's how we would do it, and try to be flexible to make sure that the patients are getting what they need, the family's getting what they need first and foremost.
Other questions out there? Well, thank you guys for joining.